Kids do not like masks. So you're not agitating them by trying to put a mask on them. That's why it's flow by. It's not nasal cannula, you know, but it's just flow by. You just take that tube and you use the bigger tube that goes with like the peace pipe nebulizer, fold it back on itself so it's got two sources coming out, tape it, and then lay it in the bed with it, okay? I should have, thank you for asking, I should have cleared that up.
Okay.
Sorry, Professor.
No,
Yeah.
okay. Professor Lavatois referred to Dr. Peck, who is a radiologist who is going to be talking to you guys about general radiology plus normal x-ray and abnormal chest x-ray. I was just conversing with him this afternoon. He's scheduled for tomorrow at 1:30. He kind of forgot, or it just came up that he has to be on call tomorrow for something. So there's a possibility he might not be able to come tomorrow afternoon. So, we're gonna still keep it on the schedule, because I know there's somebody after that. I will let you know as soon as I find out. If he can't, who's after him? That's what I said. Is that it?
Yeah.
Okay, I will be conversing with her to see if she could move up, if he can't come in tomorrow. If he can't come in tomorrow, we're gonna work on Monday, okay? Again, it's kind of full that day, but hopefully we could get him in about 1 o'clock and shove the other two, Dr. Latassi and Dr. Britton, down to later in the day. I told him very last option, which I really don't want to do, but if we have to, we will on the Tuesday. I'm going to try my darndest to keep that entire day open for study. But I just wanted to kind of give you guys a heads up that we're kind of in limbo as far as what his availability. Okay, we'll get him in at some point, but I apologize for that. That's the difficulty of getting these, you know, physicians, PAs, and I mean, they're the best to talk to you that work in that specialty, but we have to work with their schedules. So, yeah, I really met him, but she has.
Oh, he's great.
Yeah.
You gotta love that kid, I'm telling you. But really, you guys should be studying up. So even if it gets pushed back to Tuesday, it's not like we wait and then start studying for the exam Tuesday, right? So we should be keeping up with it anyway. Yes.
Well, and,
no, I'm just, no.
and he did say, well, if I have to come later, then they'll know more pathology, and I don't have to teach as much about pathology and talk more about just the findings on X-ray. So, okay.
Thanks, guys.
Thank you.
Okay, and again, I just thank you for bringing to my attention that you guys have had some cystic fibrosis and actually had some just 30 minutes ago.
Can I interrupt you real quick?
Yeah.
I'm so sorry. I didn't mean to send it to the whole class.
Oh,
I
that's
had an
okay.
accident to reply to all, so.
Oh, no, it
Talk
was,
with you about
there was a couple of you guys that let me know that, and I appreciate that. I just wanted to make sure that you knew that it would be on the test, since there wasn't a planned specific lecture, so I wanted to make one, and I wanted to focus it a little bit more towards pulmonology. And again, we'll breeze through this pretty quickly because I think you've been through the majority of it. Okay, so we know that it's a genetic condition. It's the most common cause of severe chronic lung disease in young adults. Most common fatal hereditary disorder of whites. You're going to see this a lot more in the Caucasian population versus other groups of people. It's autosomal recessive. We call it an exocrinopathy, okay? Abnormality to the exocrine glands. Exocrine, oh my God, I can't talk, it's easier for me to say. Exocrine glands produce and secrete substances onto the epithelial cells, okay? These are examples via a duct. So these are examples of various exocrine glands. And it basically, cystic fibrosis will affect any or all of these glands. Okay, so the protein, there's a gene that kind of tells, codes for this protein, the cystic fibrosis transmembrane conductance regulator protein, okay, CFTR protein. That is where the defect problem is. There is about, I think, over 1,000 different gene mutations. They know of a couple hundred of them that give clinical symptoms. Of all of the gene mutations that are out there, that DF508 is the biggest percentage of where that defect problem occurs, okay? So when there's an abnormality in this protein, there is a change in how chloride and water transport into or to the surface of these epithelial cells. You have to have that water and chloride transfer to keep mucus thin and movable. Okay, when there's that abnormality, that mucus and whatever secretions get very thick, viscous, and don't move very easily. So, any of these exocrine glands can be affected. The biggest one in cystic fibrosis is pulmonary, and probably the next, the pancreatic. Okay, so the main mortality and problems associated with cystic fibrosis is its effect on the respiratory system. Very hyper thick adherent secretions that block these bronchioles, medium to small sized airways, and then that leads to chronic or intermittently chronic infection. Bless you. Things that how they're going to present if they're older: cough, sputum production, not able to exercise as much as they used to, wheezing, recurrent pneumonia, shortness of breath, hemoptysis or blood, coughing up blood, and as Professor Mothertois said, they have a lot of nasal and sinus infections as well. The pancreas, when there's abnormalities there and blockage there, then the pancreas is not able to excrete those digestive enzymes to break down food and fat, and therefore they have problems with malabsorption. The kiddos don't grow properly. They kind of call this failure to thrive. Steatorrhea is when you have fat in the stool. Diarrhea, abdominal discomfort. And they can also have salty tasting skin, which is kind of an interesting thing. Another thing I found interesting is that about 99% of men that have cystic fibrosis are sterile. Okay, so on exam you may see the digital clubbing like we talked about. Again, we're not oxygenating well. The barrel chest, okay, that increased AP chest diameter, hyperresonance. Again, all of, well, at least those two, the chest diameter, the barrel chest, oh my God, I'm sorry, and the hyperresonance has to do with the air traffic. Apical crackles. So crackles generally more in the upper part of the lungs. I have no idea why it's more in the upper part of the lungs. To me, I would think of it being further down, but I don't know. Okay, so again, I want you to know intermittent, chronically intermittent infections, staph aureus and H. influenza are the big ones early on in life. You need to know Pseudomonas as they get older, though. That will be on an exam. You will see this in the future, whether it's my test or in NCCPA exam. Another one that is a gram-negative that is not good for how a person progresses is this Burkholderia Cepacia. I'm sorry, I'm not pronouncing that very well. I had not even heard of this. Oh, yeah, you should know. I had not even heard of this, but this is one that is not real commonly seen, but can be, and when it is, it's not good. This is very, very resistant to antibiotics. So, and you have just this chronic infection, obstruction, you know, just destruction of the lung tissue, lung parenchyma. Nowadays, for the diagnosis, nowadays they're doing, not when I was in school, but nowadays they're doing newborn screening routinely, and with that they check this IRT, or immunoreactive trypsin level. And kiddos that have an elevation in this, it is suggestive of cystic fibrosis. If they have a positive screening, then they need to follow up with the sweat test, and you need to know the sweat test, because that's kind of the main thing that's been used for a long period of time. And that's just when they have elevated levels of sodium and chloride in their sweat. They have to have 2 tests on 2 different days to be considered positive. Nowadays, they can do more gene testing with the genes and genotyping, which they didn't used to have that, but now they may jump into that earlier. Okay, so one thing I wanted you to know is that if you're highly suspicious that a person has cystic fibrosis and you run a chloride test or sweat test and it is negative, that doesn't necessarily rule it out. You can do some further testing, such as the genotyping, or there are these other testing. I'm not that familiar with them, but there are other things that can be done if the initial testing is negative and you have a high suspicion. Okay, for treatment, you want to get them into a specialized cystic fibrosis center. OU has one. In fact, the gal who's talking to you about PFTs and spirometry and that sort of thing, she works over there at the cystic fibrosis, whatever, clinic. It's a comprehensive, you have, I'm sure, respiratory therapists, and we'll talk a little bit more about that. So we want to aid these patients in thinning that mucus and getting it out. Bronchoconstriction, if they're having airway bronchoconstriction, you need to treat them with bronchodilators. Intermittent or chronic treatment of these respiratory tract infections, pancreatic enzyme replacement, and then obviously nutritional, probably dietitian and that sort of thing as well, psychosocial support. All right, so they do chest physiotherapy to help clear that the lung secretions. Things such as postural drainage, that's where they put them in different positions to move that those secretions around, so then they can cough it up easier. They do that in combination with chest percussion. They have handheld devices called PEP, positive expiratory pressure, and this flutter valve. These are handheld devices that where the patient breathes in normally, but they have increased pressure to when they expire, okay, when they breathe out. And this allows air to get back behind that mucus, and then they kind of help to push that mucus out. The flutter valve pretty much does the same thing, but it adds a little bit of vibration when they during expiration, and that just helps, I guess, to loosen that mucus up also. A directed cough, a huff cough is kind of where it's not a spontaneous cough, but they just encourage them to play cough, I guess. Do 1 or 2 forced expirations, usually after they've done some of these other techniques. And these are examples of the postural drainage, the different positions, percussion, the valve, and the flutter valve. Okay, treatment, they have pulmozyme, which helps, it's a inhaled recombinant human DNA. This helps decrease that sputum viscosity. They found that when a person did this daily, it helped significantly. I'm not gonna expect you to know exactly how it helped, but know that that's part of the treatment. Probably as primary care providers, I would suspect you're gonna be dealing more with just the chronic intermittent infections, rather than prescribing the pulmozyme and some of these other protein modulating medications. I think the specialty clinics will be doing that, but I just wanted you to be familiar with what's out there. The hypertonic saline twice a day, again, helps to thin that mucus. Short-term antibiotics, long-term antibiotics. Long-term antibiotics they did. You don't typically think of them using long-term antibiotics, but they mainly use this when they have confirmation via sputum culture that they are colonized with Pseudomonas. And so they may just chronically try to keep that bacteria down so that it causes less exacerbations and infections, okay? Inhaled bronchodilators, your albuterol to help with wheezing and constriction. Again, you're going to do that if they've had PFTs, pulmonary function testing, and when they challenge them with a bronchodilator and they actually show improvement by 12%, then they're going to recommend that this be kind of a daily part of the regimen. And then they have modulator therapies on that actual protein, that CFTR. Again, I'm not going to get real specific with this. I just want you to be familiar that these are out there. They actually help, well, they basically, they work for certain gene mutations. They don't work with everybody. But since the largest percentage have that one gene mutation, it can help with a lot of that. So most people who have this, especially that gene mutation, you should try to get on this, or whoever's treating them should try to get them on this. It basically helps to keep those channels open so that the chloride and the water can get through more effectively, and it was found to increase the lung function by 10% within 2 weeks after treatment, and decrease those pulmonary exacerbations by 55%. That is significant. So this is, I don't know personally how readily insurance likes to pay for this. That's always the hurdle, it seems like, with some of these good newer products. So lung transportation is really the mainstay for very severe end-stage cystic fibrosis. Pancreatic enzymes, like we talked about. You always want to vaccinate these patients in your primary setting. Make sure they're getting pneumococcal vaccination as well as their annual influenza vaccine. Screening possibly for family members, since it is a genetically driven problem. Median survival, it used to be where these people died in childhood. Now they're reaching up into their 40s. So we've come a long way with not curing, but managing this so that people live longer. Deaths are most often due to pulmonary complications, pneumonia, pneumothorax, or just terminal chronic respiratory failure or cor pulmonale. We're going to have a talk about cor pulmonale. That's basically where, because of you have such pressure in those lungs, that right ventricle or the right side of the heart, it has such a hard time pushing the blood into the lungs that you get right-sided heart failure. After transplantation, the median survival is about 7 to 8 years, so better than I had anticipated. And then I gave you this website for these protocols and therapy protocols for these patients. And And that is it. Any questions about cystic fibrosis? Okay. I want you to now be able to recognize if I give you a case scenario of, how a patient might present.
I think in Dr. McNeil's lecture, he said that sometimes they'll have lung transplants and stuff like that. When they do that, will those lungs also get damaged and stuff too, or will that still be a problem?
I'm not 100% sure on this. Let me do a little bit of a cure for the lungs, but not for the so you still have and diabetes, there's about 30% of people with cystic fibrosis have diabetes due to pancreatic, how the pancreas, you just damage the pancreas.
Would they get like one diabetes? Or have like one diabetes?
Hey, thank you guys. Thank you. I appreciate it.